Hello. Today we're going to go through chapter 21, blood vessels and hemodynamics. We have many different types of blood vessels in our body, and they all carry some sort of job with delivering blood to different areas. Arteries are the blood vessels that carry oxygenated blood away from the heart. You could be carrying it to the skin, muscles, bones, any of the organs in your abdominal or thoracic cavity. Arteries are trying to get nutrients out to other areas of the body. We have many different types of arteries. We have large elastic arteries. These are the arteries closest to the heart. They start to split off. They will split off into medium-sized muscular arteries as they continue to travel further and further away from the heart. These medium-sized arteries are going to turn into smaller arteries, which are going to divide into what are known as arterioles. Arterioles are the smallest arteries that we have in the body. Capillaries. Capillaries are technically the tiniest blood vessels in the body, the tiniest. They are smaller than those arterioles. They are very thin-walled because capillaries is where we exchange substances. We deliver oxygen, glucose, other nutrients to the cells. We pick up carbon dioxide and different cell wastes through blood capillaries. And then we have our veins. Veins are carrying that deoxygenated blood back to the heart. Our capillaries actually drain into what are known as venules. Venules are the smallest veins. Just like the arteries, as they leave the heart, get smaller and smaller and smaller, veins start small and get larger and larger and larger as they travel back to the heart. So when new blood vessels are formed, this whole process is known as angiogenesis. Genesis means to make or build something. So looking at different root words within words can kind of tell you what they do. So angiogenesis is going to build new blood vessels. They start developing in embryonic life, so that's that first 8 weeks of development, and then into fetal. That is past those 8 weeks through birth. After we're born, if blood vessels get damaged, you get a cut, that blood vessel gets damaged. It's going to have to reform. It's going to help heal wounds, go through different wounds, any scar tissue. Helps to make that uterine lining after menstruation. The corpus luteum after ovulation. These are all things that we will go through in the female reproductive section. They may form new blood vessels to go around an obstructed artery. It happens in coronary circulation. It may happen other places in the body as well. Tumors, cancerous, malignant tumors, they're going to secrete tumor angiogenesis factors. This is a protein that stimulates blood vessel growth into that tumor, provides those tumor cells with the nutrients so they can continue to divide at very rapid rates. Scientists, ways that we're trying to figure out how to stop cancer, they're trying to inhibit this angiogenesis, trying to prevent tumors from sending out these proteins and these tumors starting or continuing to grow. Diabetic retinopathy. Diabetic retinopathy angiogenesis. Diabetes causes a lot of different problems in the body, and one of those can be blindness. So diabetic retinopathy, they lose sensation in their fingers and their toes because they're not getting enough blood and nutrients to even the nerves in that area, so they start losing those sensations. They can also work with trying to build blood vessels to prevent that blindness that comes with diabetic retinopathy. So there's a lot of things that scientists are working with angiogenesis and trying to either prevent it or in some cases promote. So let's go through the different layers of the blood vessels. All blood vessels are going to have certain structures to them. They're going to have these different layers. We have the tunica interna. That is the interna, it's the innermost layer. So it kind of tells us in its name. Interna, it's the innermost. So that's what kind of lines the inside of that blood vessel. The tunica interna is made of some layers itself. It's got the endothelium. That's going to tell us that it's endothelial cells. Endothelial cells are actually going to line the insides of those blood vessels. They have a basement membrane. Those endothelial cells need to attach to something. So just like in our skin, when we talk about other organs down the road, they're going to have a basement membrane for those endothelial cells to actually attach to. They even have an internal elastic membrane with elastic fibers. Because these cells, these blood vessels need to be able to stretch. So these elastic fibers not only allow it to stretch, it allows it to recoil back. The next layer is the tunica media. Media for middle. Since we cannot control the size of our blood vessels, it is made of smooth muscle. Smooth muscle is that involuntary muscle that we cannot control. There's also going to be elastic fibers in there because, again, when something stretches, it needs to be able to recoil back. And elastic fibers allows for that stretch and recoil. The tunica media, the smooth muscle, is what allows our blood vessels to get larger or smaller. They're going to, it says, regulate the diameter of that lumen. That opening in the middle of that blood vessel where the blood travels through, that's that lumen. So that smooth muscle is what's going to regulate the size of that. When our blood vessels go through vasoconstriction, constrict means they get smaller. That is a sympathetic feature. That sympathetic stimulation on our blood vessels narrows the lumen. So those blood vessels get smaller. Vasodilation. It dilates, it gets bigger. So we decrease that sympathetic stimulation. Those blood vessels that smooth muscle will relax, those blood vessels get larger. This tunica media is what regulates that blood flow through these different blood vessels. How much blood can go through at a time through this vasoconstriction or this vasodilation. And as I mentioned in the heart chapter, We regulate our blood pressure with this vasoconstriction and this vasodilation. The smaller the blood vessel is, the harder it is to push that blood through, the higher the blood pressure. The larger the blood vessel is, the easier it is to push that blood through, the lower the blood pressure. Blood vessels also have a way of trying to prevent too much blood loss. The tunica media plays a role in this too. If you cut a blood vessel, the smooth muscle around that blood vessel will do what is called a vascular spasm and close off that blood vessel to prevent too much blood from coming out. While the platelets and that whole platelet plug gets formed, these blood vessels are going to cut off too much blood so we can heal this blood vessel without losing a ton of blood. We have an external elastic membrane. This is on the outside of that smooth muscle. It's that middle between the tunica media and that next layer, that tunica externa, which is also known as the tunica adventitia. This is the outermost layer of our blood vessels. So it's going to surround any tissues around this blood vessel. So the tissues that sit outside of that blood vessel, that tunica externa is going to be in contact with it. It's a lot of elastic fibers, because again, our blood vessels need to be able to stretch. There's also collagen fibers in there because they need to be strong. Collagen is a very strong fiber. We also have nerves because our brain helps to regulate the size of our blood vessels, whether they're going to be vasoconstricting or they're going to be vasodilating. We need nerves going into these blood vessels that go to this smooth muscle to help regulate that. This is where this vasa vasorum comes into play. In our very large blood vessels, not only do we have nerves, our blood vessels have their own blood vessels, because that smooth muscle needs nutrients to be able to work. It needs oxygen, needs glucose to be able to generate that ATP to allow that smooth muscle to constrict or dilate. So if we look at some of these different blood vessels, we just looked at generally what we have. We see this tunica interna. We see it in both the arteries. They draw in red, or most arteries are drawn in red, but it's more that they're oxygenated versus the veins. They tend to draw in blue more because they're deoxygenated. That is what those mean, just like I mentioned with the heart, and where people get confused with the pulmonary arteries and the pulmonary veins being different colors. The rest of the body, arteries are going to be red, veins will be blue. We can see this thin layer of endothelial cells that lines the inside of that blood vessel. That artery, it does the same in the veins. Even these capillaries have that endothelium in it of epithelial cells. We see this tunica media that has this smooth muscle. You can see the difference in thickness. The arteries, the smooth muscle is a lot thicker than in the veins. And then we have that tunica externa. Those elastic fibers and those collagen fibers on the outside. These are some good videos that kind of goes over the different anatomy of arteries, capillaries, and veins for you. So with our arteries and arterioles, the large and the medium, even the small arteries into arterioles, they all kind of have this same sort of structure. That endothelium is attached to that basement membrane. That gives those epithelial cells something that holds them down. Then we have that internal elastic membrane. Next is that tunica media of smooth muscle. Again, we have that elastic membrane that separates that tunica media from that tunica externa on the outside. If we look at the slide of an artery, you can see that tunica externa on the outside. You can see that smooth muscle in the middle, and then that tunica interna on the inside even. There's even blood cells in here. All those little dots in there, those are all blood cells. There's even some white blood cells I can see with a darker nuclei. So as I've mentioned, arteries are what carry the blood away from the heart. They are going to have that elastic wall because remember thinking back to the heart chapter, the previous chapter, when those ventricles contract, they are taking a lot of pressure to push that blood out of those ventricles through that valve. So especially that aorta, that first artery that the blood hits when it leaves the heart, it's very elastic because it needs to absorb that pressure. That smooth muscle in the tunica media is going to regulate the diameter of those blood vessels as well. So they're going to make sure those blood vessels don't get too large or too small. They're going to maintain it so we maintain our blood pressure. So we're going to go through the different sizes here. The elastic arteries, they're known as conducting arteries. They are the largest ones. So think that aorta that comes off the heart. They're very large. They're largest in the body, so that aorta is huge. We'll kind of look at how big it is in lab. So they do have that internal and external elastic membrane, or that elastic lamina. There's not as much smooth muscle in the elastic arteries because these are the arteries that blood is leaving the heart, and there's branching arteries that come off of it that the blood is going to get sent out into. So these walls are going to stretch because as those ventricles contract, those walls are going to stretch to receive the pressure of that blood every time those ventricles are going to contract. And elastic fibers, their main feature is that they recoil back to their normal size no matter how far they've been stretched. So I've been mentioning that aorta. So when this ventricle down here contracts and pushes that blood through that semilunar valve, that aorta is going to stretch to absorb some of that pressure. And then as the blood just continues on, it's going to leave that aorta and travel many different places around the body. Let's look at our medium-sized arteries. Those are those muscular arteries, also known as distributing arteries, because they're coming off of that aorta, so they're distributing that blood to different areas in the body, like the head, the neck, arms, all the organs in the abdomen, your legs. These are the different arteries that come off of those large arteries. So there's a lot more smooth muscle in there. Smooth muscle makes up almost 3/4 of the size. So they're able to vasoconstrict and vasodilate very easily to regulate how much blood flow is coming into that area. As I mentioned, these are branching. They branch off and go many different directions. That tunica externa is pretty thick. That tunica media, that has that smooth muscle in it. It's also going to contain some fibroblasts and elastic or collagen fibers. Muscular arteries do not have the ability to recoil and help propel blood. So they don't squeeze down, contract, that smooth muscle doesn't contract and that lumen gets smaller to push that blood forward. They maintain some sort of vascular tone. So they maintain a partial contraction. That's what helps to keep that blood flowing, is that partial vascular tone. Blood just keeps flowing forward as that blood tries to push against that partial contraction to absorb some of that pressure, but that pressure doesn't, it keeps pushing forward. It causes that blood to keep moving forward instead of stretching that vessel out. That is where this vascular tone of muscular arteries comes into play. Many of our blood vessels are going to branch. They may branch, go around something, and reunite somewhere. An anastomosis, that is the union of the branches of two or more arteries. So two arteries are coming together. That's an anastomosis. We've got several of these around the body, but it also provides this alternative route for blood. So something happens to one of those arteries out of the two, maybe two that come together. So we have these two blood vessels. They're coming together. Something's happened here. Blood can't flow. Well, it can still flow down that way. So this is how an anastomosis will tend to help. We also have collateral circulation. So blood vessels get blocked. The circulation does not stop because, again, this anastomosis, this is the collateral circulation. Exactly what I just drew. This blood vessel here, something happens to it. Blood can still go down this way and still can get to the remaining part of the body. Maybe it's down your leg. We have several anastomoses through our knees, through our elbows. So blood still gets down to your fingers and your toes. We do have some end arteries. End arteries are arteries that do not form an anastomosis. So if that artery, we have some artery going along, gets blocked, anything past this blockage here cannot get blood. So this is where tissues start to die, or as it's called, necrosis. That's where tissues die because they're not getting the nutrients that they need. Next size down. So we've gone through large arteries, medium arteries. Now we're going to go into arterioles. They are the smallest arteries in the body. They actually regulate how much blood flows into the capillaries at any time. They still have that tunica intima. They have that tunica media of those smooth muscle cells. We have different types of arterioles. We have a meta-arteriole. That is that end of those, the very end of that arteriole. That meta-arteriole leads into capillary beds. So they lead towards that capillary junction that comes next. At the end of that meta-arteriole, we have a precapillary sphincter. This sphincter is going to open and close to monitor and regulate the blood flow that is going into that capillary bed. So blood does not go through that capillary bed at such a high speed, it kind of slows things down. Because as we get to our capillaries, we'll see just how small capillaries really are. We cannot have high pressure going into those capillaries. So resistance. Resistance is the opposition to blood flow due to friction between blood and the walls of blood vessels. So our arterioles play a role in this. They are known as resistance vessels. And it's because the blood, as it's going through those vessel walls, those vessels are getting smaller and smaller and smaller. The smaller the vessel diameter is, or the width of that vessel, the greater the friction, the more resistance, the harder it is to push that blood through, the smaller those vessels get. So when that smooth muscle contracts, it causes that vasoconstriction, so those blood vessels are getting smaller. The smaller the blood vessels, the larger the resistance into that blood vessel, which decreases the amount of blood flow. Even changing the arterial diameter can affect your blood pressure. Vasoconstriction of these arterioles is going to increase your blood flow because vasoconstriction, where blood vessels at rest, this is the inside lumen. We vasoconstrict it, we make it smaller. It's harder to push blood through that. If we go to vasodilate, our blood vessels are going back to its normal size. So that's going to decrease that blood pressure because it makes it easier for that blood to go through that vessel when you dilate the blood vessel, so that lowers your blood pressure. It takes less work. The higher the blood pressure, the more the blood vessels are either vasoconstricted or they're just smaller in general. Could be from atherosclerosis or something that's built up in the walls of those blood vessels. But vasoconstriction, just because it takes a lot more work to push that blood through. So here's capillaries. Here's a nice slide of a capillary. Capillaries are so small that these blood cells need to go through in a single file line pretty much. So that's why those arterioles have to slow down that blood flow so much to allow these blood cells to travel through in a single file line. Capillaries are where we exchange out our nutrients. If we look, we have the endothelium and a basement membrane here. That is it. That is, that's why the blood vessels are so thin, it allows for easy diffusion of nutrients in and out of those blood vessels. So this video kind of goes through and shows the capillary exchange, how all of this happens. We find our capillaries between arterioles and venules. So this is kind of the last place our blood cells go to before they head back up to the heart. It's that single layer of those epithelial cells with that basement membrane. And as I mentioned, this is where we exchange nutrients and wastes between the blood and the tissues. And it is all done through diffusion. Or if we're exchanging fluid, it's osmosis. Capillaries branch significantly. So one arterial right here, this is our arterial. It contains these capillaries that come off of it, but there's these sphincters. We've got our meta-arterial, actually, this is our meta-arterial down the middle. These little sphincters, let me change colors so we can see. Right here, 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 here. These are all different sphincters that are going to either allow the blood to travel through these capillary beds, or in this second picture, when they're constricted, they prevent the blood flow going through this capillary bed. We have capillaries that go through every single tissue in our body because that's how all of our tissues get their nutrients. So these sphincters are going to regulate the blood flow into these capillaries to get these nutrients out. So we have different types of capillaries, and these different types of capillaries are going to allow for certain things to happen. Our continuous capillaries. Our continuous capillaries, they're the most common type. They're the ones we find the most in the body. So those epithelial cells come together and they form a complete tube. This tube is known as this intercellular cleft. There are slight gaps, as we can kind of see through here, that does allow some of this stuff to get passed along. Central nervous system, your lungs, your muscle tissue, your skin, they all contain continuous capillaries. Fenestrated capillaries. If we look at these endothelial cells, they've got lots of little holes. These little holes are known as fenestrations. The fenestrations allow for different things to get through those cells a lot easier. So our kidneys, we filter a lot of things out in our kidneys. Our intestines, that's where we absorb a lot of different nutrients into the bloodstream. Those fenestrations allow us to absorb vitamins, nutrients, glucose into the bloodstream. The choroid plexus in the brain, that makes that cerebral spinal fluid. We need fluid, glucose, maybe different ions to be able to travel through. Those ciliary processes of the eye that make that aqueous humor in the front portion of your eye, we need to be able to get that fluid because it comes from the blood in and out. And then most of our endocrine glands are also going to have fenestrated capillaries because those hormones need to be able to easily get in and out of those blood vessels. Our last type of blood vessel, or capillary, I should say, is a sinusoidal capillary. As you can see, those cells are very holy. That basement membrane is very holy. They wind a lot more. They may have that basement membrane, may not. This is what allows different proteins to get in and out of the blood. So in our liver is used to store different things. It's used to detox. It's used for a lot of different things, but these capillaries that go through the liver allow proteins to get in and out of the blood. Our red bone marrow. How do our red blood cells that we're making in our red bone marrow get into our blood? Sinusoid capillaries. The spleen cleans out old red blood cells. So these blood cells need to be able to get in and out. Pituitary, parathyroid, suprarenal glands, again, hormones. Veins. Let's look at veins and venules. One of the main differences with veins is they have what are known as a valve. This valve comes together and its job is to prevent blood from flowing back down. Think in your legs. That's a good example because if you're on your feet, how does blood get back up to the heart? Well, these valves help. Every time a muscle contracts, it's actually causing blood, pushing blood up. And then those valves prevent that blood from falling back down when that muscle relaxes. So every time that muscle contracts, it pushes blood up. Those valves prevent that backflow. This is how blood, especially from the legs, I mean, we have valves in all of our veins and venules, but that's just the best example, just because it's got a long way to travel up to get to the heart. But those valves are preventing that backflow of blood. We still have that tunica intima, those epithelial cells. We still have that basement membrane. We have that tunica media of smooth muscle. It's not as thick as arteries because arteries are what maintain our blood pressure. Veins are just trying to get that blood back to the heart. Then that tunica externa, that connective tissue on the outside. So we have a couple different portal systems that are veins, technically. So when blood passes through the capillary network, and sometimes it's going to go through a portal vein, which is known as a portal system. That portal system actually gives rise to a secondary more capillaries. So if in the liver, we have these capillaries that are absorbing different nutrients in our small intestine. As these nutrients are getting absorbed and through these capillaries, they're going back into veins. These veins are turning into this portal vein that goes to the liver. The liver, we're going to have more capillaries so we can distribute these nutrients into the liver. So we do have a vein that goes into the liver, the portal vein, that is actually bringing nutrients from our digestive system into the liver to store them. The pituitary gland does the same thing. So these venules, we went from large arteries, medium arteries, arterioles, meta-arterioles that have those sphincters that allow for blood to enter into that capillary bed. On the other side of that capillary bed, we have venules. They are the smallest veins. They don't maintain that shape. They don't maintain that nice, pretty round vessel like an artery would. Blood from those capillaries are draining into that venule. This is how this blood is starting to head back to the heart. So we have this post-capillary venule. They're receiving the blood from capillaries. We still, in these venules, at this point, we're still exchanging nutrients and wastes. White blood cells may emigrate, where they leave the bloodstream. This can still happen in venules, not as common as capillaries, but it does happen in the beginning of venules as well. So as we start to move away from those capillaries, we start to gain some layers of smooth muscle that capillaries do not have. These venules drain the blood from the capillaries, they go to the venules, and then they go into veins. Muscular veins, just like we have muscular arteries, we have muscular veins. Their walls are thicker than the venules. At this point, we don't want nutrients to start to leave that, or different wastes to start to leave that bloodstream. So at this point, we are trying to get rid or keep whatever's in the blood there. Here's the interesting part with veins. They are a reservoir. More of our blood sits in our veins than they do anywhere else in our body. Because it takes more work to get these veins, to get this blood back to the heart. So blood tends to accumulate in the veins. Veins, we go from venules. Several venules come together to form a vein. These are getting larger and larger as we continue to get closer to the heart. They still have a very thin wall. They're not as thick as those arteries were. They still contain that tunica intima, tunica media, tunica externa. They do allow for some pumping action to help push that blood towards that heart. So that smooth muscle is trying to help move it, and those blood vessels are trying to help move that blood up. Those skeletal muscles, as I mentioned, every time a skeletal muscle contracts, it's pushing blood closer to the heart. But the blood pressure in the veins is a lot lower, a whole lot lower. If you've ever cut an artery versus a vein, this is why we draw blood out of veins instead of arteries. I mean, there are some procedures for drawing blood from arteries, but 99%, maybe not that much, but majority of the time we draw blood from veins, because in a vein, blood leaves in an even flow. It's just kind of a continuous oozing. An artery will spurt every time your heart pumps, you get a spurt of blood that comes out every time. As I mentioned, those veins have valves. This is technically made of that tunica intima that makes these flaps. These, again, as I mentioned on the picture before, they prevent the backflow or the backup of blood. We don't want blood pooling in our legs if we stand all day. So every time that, say, a muscle contracts and it pushes blood up, those valves prevent that backflow. The muscle contracts again, it pushes that blood up, that valve prevents that backflow. So here we can kind of see these valves and how they kind of work to prevent this backflow. So they kind of come up here, come up this way. They're working to prevent blood from flowing back down from where it just came from. So again, we have different kinds of veins, just like we have different kinds of arteries. A vascular sinus. A vascular sinus is actually an area where blood collects before it drains out of somewhere. The dural venous sinus in the skull is a great example, because blood that is going around the brain, as it goes through all those different capillary beds, it actually empties out into the dural venous sinus, which is eventually going to empty out into a larger vein. We have anastomotic veins. And this is where veins are paired and they accompany other veins. And we just have double sets of them. Again, in case something happens to one of the veins, there's still a way for blood to get back to the heart. And then we have superficial veins. These are ones, they tend to be unaccompanied by parallel arteries. We have superficial veins. We have deep veins, and they usually form anastomoses along the way. And this is just the blood that is moving back towards the heart. They're just going from smaller vessels to larger to larger. Some places they travel up, travel around something, and these veins are just continuing to merge together as they get closer to the heart. So this is a nice chart from your textbook that goes through all the different types of blood vessels, what size they are, what layers they contain, and what their main function is. It's a nice everything in one place. Varicose veins and spider veins. I'm sure some of you have heard about varicose veins. Varicose veins occur because those valves don't work. Those valves don't work well at preventing blood from flowing back down after it gets pushed up. That blood just keeps coming back down. Gets pushed up, goes back down. Gets pushed up, goes back down. Since blood cannot make its way back up, that blood starts to pool and collect. That's what causes these veins to get that dilated look. They may start twisting around and kind of weaving just because they're not able to get rid of the blood that they have. Spider veins. These are venules that are close to the skin that kind of get dilated. We see them a lot in the legs. You may see them in the face. They can appear different colors. They kind of resemble a spider web. That's why they're called spider veins. So here are some varicose veins. They really stick out because they're very dilated. There's lots of blood in there. So as I said, in a normal vein, this blood goes through this valve, and then these valves prevent this backflow. But in a varicose vein, this blood goes up, the valve doesn't close, blood goes back down. And it's a process that just keeps happening over and over and over again. Most of the blood is in your veins and your venules. That venous system is known as the blood reservoir. That is just where most of our blood in our body is actually found, especially at rest. Well, probably right now while you're sitting and listening to this, unless you're actually running or walking on a treadmill or on a bike or something while you're actually listening to this, your blood, majority of it is found in your veins. So as I mentioned with the capillaries, most stuff goes through by diffusion. We do use some transcytosis, some bulk flow, but majority of it is diffusion. So diffusion is the movement of particles across a semi-permeable membrane. That's the actual definition of diffusion. So particles, oxygen, carbon dioxide, glucose, amino acids, hormones, they can just simply diffuse across that membrane. Because capillaries have those spaces between those cells that allows things to easily travel through. Diffusion is when something is moving across its concentration gradient. So it is moving from an area of high concentration to an area of lower concentration. So there's a lot of oxygen in the bloodstream. That oxygen wants to go from where there's a lot of oxygen to where there's a little bit of oxygen. Carbon dioxide does the exact same thing. Outside of those cells, there's a lot more carbon dioxide. So it wants to go into that bloodstream to kind of technically thinking that it wants to even itself out. So transcytosis. So we have some stuff that are in these tiny pinocytic vesicles in our blood. So that transcytosis, say we have a cell here. Remember back to chapter 3, stuff is going to come in, kind of fuse with that membrane, make a vesicle. That vesicle is going to go on to the other side, fuse with that membrane, and let its products out the other side. That is transcytosis. Lipids. Insulin. This is how things get across the membrane. A lot of lipids get across the membrane, I should say. Bulk flow. Again, it's passive. We get rid of ions, different molecules, when everything kind of moves in the same direction out of the cell or out of the capillary bed or back in. Because we want to regulate the volume of blood and interstitial fluid. That's that fluid that sits around those cells. We want to maintain that, so we use bulk flow to maintain that. And we use filtration. That is when we use pressures to move fluids and different solutes into that interstitial fluid, and we also absorb through bulk flow. So thinking your intestines, we absorb a lot. We also absorb wastes from cells. So it has to go through this way. It's either going to be done through blood hydrostatic pressure, and that's that pumping action of that heart, or an interstitial fluid osmotic pressure. So we have a lot of different pressures that are happening within our blood vessels. We have net filtration pressure, and that's going to determine the volume of blood and that interstitial fluid. We want to keep that volume of blood and that interstitial fluid pretty stable. So this net filtration pressure, we'll talk about this again when we get to kidneys and the urinary system, but this is helping to kind of maintain that blood volume. We have blood hydrostatic pressure, and this helps to push things out of the capillaries. Pushes those different proteins, pushes those different nutrients out. Interstitial fluid hydrostatic pressure, it's the exact opposite. So we're going to take stuff from that interstitial fluid and push it back into the capillaries. Blood colloid osmotic pressure, it's caused by the colloid suspension of large proteins. So the different proteins in that blood are helping to cause this pressure, while we have interstitial fluid osmotic pressure. And this is pulling fluid out of the capillaries into that interstitial fluid. These are just the different pressures that we use in our blood vessels to maintain chemical levels. We maintain fluid levels, both inside and out of the blood vessels this way. We keep maintaining and filtering through our blood vessels with our lymphatic system. We'll go through the lymphatic system in the next chapter, which is our lymphatic and immune system. We'll talk about that in the next section. But we kind of maintain different pressures to help keep blood flowing through and keeping fluid levels somewhat steady. I'm not going to ask you to calculate this all out because I'm not going into a lot of detail about it. So it's just kind of to let you know this is how different things move into or out of the bloodstream. This is where we have Starling's law. Starling's law states that under normal conditions, the volume of fluids and solutes reabsorbed is almost as large as the volume filtered. So in our capillary beds, we are getting rid of, we're releasing out glucose, we're releasing out oxygen, we're releasing out other nutrients, we're absorbing carbon dioxide, we're absorbing different cell wastes. So we're absorbing and filtering, and that volume is pretty large of what we're going through. So blood flow is the volume of blood that flows through any tissue at any given time, and it's measured in milliliters per minute. So the total blood flow, we have this cardiac output, the volume of blood that circulates through the systemic or pulmonary blood vessels each minute. So cardiac output, we take our heart rate times our stroke volume. That'll give us our cardiac output. We can also take our mean arterial pressure and divide it by resistance and get our cardiac output. Those are two different ways to calculate cardiac output. Unless you're going to work in cardiology of some sort, you'll probably never see this again. But if you go to work in cardiology, they will ingrain it pretty well. So this is a nice animation that kind of goes through how we regulate fluids in our blood along with other substances that are moving in and out of our blood. Edema. Edema. We're filtering out more fluids out of our blood than we are absorbing. This is what causes fluids to collect outside just within the tissues. Unfortunately, we can't always detect it until it is about 30% above normal, because by that time it is actually visible that we can see the accumulation of fluid at about 30% above that normal. And there's two things that may cause this. So we have increased capillary bed pressure. So more fluid is being filtered out of the capillaries. We have increased permeability of the capillaries. Again, more fluid is being allowed out of those capillaries. Could be chemical, bacterial, thermal, or mechanical agents that are acting on these capillary walls. We also have a decreased concentration of plasma proteins. That colloid osmotic pressure gets affected. Liver disease, burns, malnutrition, kidney disease. These are just some things that are going to cause more fluids to get filtered out than gets reabsorbed. Hemodynamics. Hemodynamics is the force that allows for blood to circulate throughout the body. So our blood flow is just the amount of blood that flows throughout any tissues. Any blood flow that is flowing through your arm, per se, or your leg, or your foot, or your hand. So our total blood flow is the same as that cardiac output. So that heart rate times that stroke volume is going to give us that cardiac output. Blood pressure. Everybody has had their blood pressure taken anytime they've gone into a doctor's office. Blood pressure is generated by the contraction of the ventricles, because those ventricles are what's pushing that blood outside of the heart, either into the systemic circulation or the pulmonary circulation. So what we're able to measure is that hydrostatic pressure that is being put onto the blood vessel walls every time those ventricles contract. It's highest in the aorta, your blood pressure, and those large systemic arteries, which is why we usually in an adult are going to check blood pressure in your arm, because we have some larger systemic arteries in your arm, even in your leg, that allows for baby. Sometimes we check with the leg just because it's easy, it's more space, but in the arm, just because we're still able to detect that very high pressure that is coming out of those ventricles. So a young adult male should be 110 over 70, even 120 over 80 millimeters of mercury is a normal. That's not one. There, 120. I said 120. 120 over 80 is a normal blood pressure for a young adult. Someone in their 20s, this is fairly normal. We have that systemic blood pressure, and that is the highest pressure attained in the arterial during systole. So that's that first number. The diastolic blood pressure is the lowest arterial pressure. That's that bottom one. Again, the higher the blood pressure, the greater the blood flow. So that higher the blood pressure, probably the smaller those arteries are, the harder they have to push that blood to get everything through. We will learn how to take blood pressure in lab, and you guys can practice it on each other. It's really hard to do it on yourself, but you can do it on somebody else pretty easily. So if we're looking for that mean arterial pressure, that's that average blood pressure in the arteries. So that mean arterial blood pressure is that diastolic blood pressure plus 1/3 that systolic blood pressure minus the diastolic blood pressure. So if somebody has a blood pressure of 110 over 70, we take that diastolic blood pressure plus 1/3 that systolic minus that diastolic. That equals approximately 83 millimeters of mercury. I'm not going to ask you to calculate this out. I just wanted to show you how you can plug those numbers in to get an answer. This video here will go through cardiac output interactions and how, it's an animation of this all, and it kind of shows you how a lot of this works. So vascular resistance. We use R for resistance. So that resistance is the opposition to blood flow due to friction between blood and the walls of blood vessels. The nice thing about those endothelial cells that line our blood vessels is they're very smooth. So they're trying to decrease that vascular resistance by maintaining a smooth surface for that blood to go through. The higher the resistance, the smaller the blood flow. So the harder it is to push that blood through, that gives it the higher resistance. As I said, it depends on the size of that lumen, that resistance. The smaller the lumen, the greater its resistance because it has a smaller space to push that blood through. Blood viscosity. How thick is your blood? Do we have more red blood cells than we do plasma? How long is that blood vessel? The longer that blood vessel is, the greater the resistance is as well. This is why obese people tend to have a higher blood pressure because they tend to have, as they grow more fat cells, blood vessels grow through them. It creates longer lengths for these blood vessels. Systemic vascular resistance is that total peripheral resistance. So it's all of the vascular resistances offered by both systemic blood vessels, so those arteries and those veins. How does the blood get back to our heart? I've mentioned it a couple times. Let's go through. Venous return. And it has to do with the pressures generated. Again, some of it does have to do with those ventricles contracting. That left ventricle that pushes that blood out of the heart, it's pushing that blood forward. So as it pushes that blood through that capillary bed, it starts to push that blood back through the venous system. So if there's more pressure coming out of that right side, that venous return actually decreases. If that tricuspid valve does not close completely, it leaks. It causes more pressure on that right side, less pressure on that left side. As I have mentioned, we use those valves. A respiratory pump, that's how we get blood back from that pulmonary circuit. Every time you breathe, you're squeezing blood vessels up those valves. And that skeletal muscle pump that I keep mentioning. So every time you contract a muscle, it compresses on a vein and it pushes that blood closer to the heart. Every time that muscle relaxes, those valves prevent that blood from backflowing. So in this picture here, if you were just rocking back and forth on your toes, onto your toes and back down, every time you go up onto your toes, you're contracting and pushing blood up. And then that muscle relaxes, those valves prevent that blood from backflowing. You contract that muscle again, blood goes up. Every time you relax it down, it prevents the blood from backflowing. So inhalation and exhalation, breathing. Every time you breathe, that diaphragm moves down, which actually increases the pressure in that abdominal cavity, which causes the abdominal veins to compress and push blood up. Everything is created in our system to work just right, to allow everything that needs to happen to happen. So whenever you exhale, breathe out, that diaphragm relaxes and it relieves that pressure on that abdominal cavity, which allows those vessels to all relax. Again, every time you breathe in, increases pressure, closes off those veins and squeezes that blood up. So the velocity of blood, how fast is it moving? So our blood flow is that volume of blood that flows through a tissue at any given time. And it's inversely or oppositely related to the cross-sectional area of blood vessels. So as we see here, as one goes down, that cross-sectional goes up. So velocity is the slowest where the total cross-sectional area is greatest, as we just looked at with that picture. Every time an artery is going to branch out somewhere, all of its branches is greater than the cross-sectional area. This is what allows blood vessels, and that how fast blood is moving, it causes it to start to slow down, especially through those capillaries. As you can see, the capillaries here in purple, it starts at a higher speed and it starts to slow down. So we're able to exchange all of our nutrients while those blood vessels are in those capillaries. But what happens, or what causes you to faint? The medical term for fainting is syncope. It's this loss of consciousness. It's not usually due to trauma, but it could be due to a lack of blood getting to the brain. There's other things that can cause it. We have vasodepressor syncope, emotional stress, threatened or fantasized injury. Some people, all they have to do is think about it, unfortunately. A situational syncope. Pressure. When you bear down to urinate or defecate, or even severe coughing can push down and block off blood vessels, which blocks off oxygen supply, which can cause you to pass out. Drug-induced. Antihypertensives. Hypertensive is high blood pressure, so an antihypertensive would be working to decrease that blood pressure. Diuretics, vasodilators. Vasodilators causes your blood vessels to get larger. Tranquilizers. Orthostatic hypotension. This is somebody who has somewhat low blood pressure, and when they go from sitting to standing, if they stand up too quickly, they may get really dizzy because their blood pressure suddenly drops. And as soon as that blood pressure suddenly drops, not enough blood is getting pushed up to the brain. Not enough oxygen can cause some people to pass out, faint, fall, even can cause them just to fall. So how long does it take from the right or that left ventricle to contract to push that blood out into the body for that blood to actually make it back to the heart again? Here it says the right atrium. So when blood first enters the heart, goes through that pulmonary or right atrium, right ventricle, pulmonary circulation, left ventricle, left atrium, left ventricle, out through the body, and then back to the heart. It's about a minute in a normal person, in a normal resting person. It could be higher, depending on how large the person is. It may take a little longer, but in a normally it's about average is a minute. There's a lot of things that are going to affect your blood pressure. The more volume of blood you have, the more liquid in your blood even, the harder the heart has to work to push it out. Again, that skeletal muscle pump, that respiratory pump, that venoconstriction, those veins constricting. More red blood cells. Increased body sizes such as obesity, it takes longer. Those blood vessels are longer. These are all going to increase somebody's blood pressure. So what helps to regulate your blood pressure? even the blood flow through those sphincters and those capillaries. That cardiovascular center in the medulla. This is going to regulate your heart rate. It regulates that stroke volume, how much blood is being pumped out of that heart, which regulates your blood pressure. You're going to control that neural, hormonal, and those negative feedback systems that regulate your blood pressure as well. So we have neurons that regulate that heart rate, those ventricles contracting, even that blood vessel diameter. That medulla can receive information from other places in the brain, including that cerebral cortex, that limbic system. That's your emotions. A lot of your memories and emotions come from there. The hypothalamus. Your hypothalamus, one of its jobs is to maintain that body temperature. Maintaining that body temperature. When you're hot, it speeds up your heart rate. When you're cold, it slows down your heart rate. So they're all going to send information into that cardiovascular center and change what may be happening. Your book gave a good example. So you start running a race. Say you're running a 5K, about 3.1 miles. Your heart rate needs to increase. Your body temperature starts to increase. So your hypothalamus is sending information to the cardiovascular center. Your cerebral cortex, your limbic system, they're all sending information into that cardiovascular center to vasodilate. Those blood vessels get larger so blood can pass through quicker through your skin, because that's how you start to sweat. Heat starts to leave your system through the blood vessels in your skin. So all of this is happening anytime you take off running. We have a lot of different ways to regulate and monitor what is happening in your blood, what is happening pressure-wise in your blood vessels. We have proprioceptors. We talked about proprioceptors in Anatomy 1 when we talked about they monitor where your joints and muscles and your body is in space in general. So your proprioceptors are telling your brain what position your body is in at this very moment. So when you go to, if you're sitting, if you go to stand up, your brain can put that movement pattern together so you can stand up. If your brain didn't know you were in a sitting position with your joints in a specific state and you tried to get up, you'd fall over. Baroreceptors. Baroreceptors, they're monitoring your blood pressure, how far those blood vessels are stretching. Every time that heart pumps blood, those baroreceptors are sending this information into the brain. And then we have those chemoreceptors, because they're monitoring the different chemical levels in the brain. They're monitoring that pH, how much calcium, how much potassium, how much sodium, how much glucose, all those different chemicals and more. These chemoreceptors are monitoring all of that. We have cardiac accelerator nerves. They're going to speed up the heart rate. They're sympathetic. Sympathetic is that fight or flight. So it speeds up things. That vagus nerve is parasympathetic. Parasympathetic, rest and digest, slows things down. Vasomotor neurons or nerves. They're going to that blood vessel wall size. They're going to change those blood vessel sizes. We have vasomotor tone. They're the resting level. So when your body and your system is at rest, what size are those blood vessels at? That vasomotor tone is going to regulate that. So blood flow and blood pressure. We have those cerebral cortex, limbic system, proprioceptors, because we need blood going to those joints. Muscles that attach over those joints, those baroreceptors for your blood pressure. Chemoreceptors monitoring the chemicals in your blood. And then that vagus nerve, that cardiac accelerator nerve, and those vasomotor nerves are going to respond to decrease or increase that heart rate and change those blood vessel sizes. So these baroreceptors, they're measuring that blood vessel or that blood pressure. So they're monitoring the stretch. Baroreceptors are monitoring the stretch, and they're actually monitoring the stretch on that atria every time blood is being drained into those atria from either the systemic circulation or that pulmonary circulation. All of this information goes into that cardiovascular center of the medulla. Those baroreceptors, these are found in the aorta, internal carotid arteries. So those are arteries that go up into the skull. And then there's some other larger arteries in the chest and the neck that are all being monitored by baroreceptors. They are monitoring and regulating that blood pressure, making sure that we're getting enough blood pushing up, making sure that we're not pushing too much. We have a carotid sinus reflex, making sure that the blood pressure in the brain is right where it needs to be. And this is going to travel on those glossopharyngeal nerves to that cardiovascular center. So when your blood pressure falls, say you have orthostatic hypotension, you stand up fast. When that blood pressure falls, because you stood up too quick, those baroreceptors don't get stretched very much. So they're going to send impulses at a slower rate. The slower the rate those nerve impulses, it's going to decrease that parasympathetic stimulation, because that parasympathetic stimulation is that relaxation of those blood vessels. It's going to increase that sympathetic to that heart and blood vessels to constrict more. Norepinephrine and epinephrine deal with those sympathetic. Those are those two sympathetic hormones that do that fight or flight type of response. So our blood pressure regulation is done on a negative feedback. So those different receptors are monitoring the atria, they're monitoring the carotid sinus. It kind of sits where these little black dots are up here. We're monitoring all of this different information. These are different inputs. They're going into the cardiovascular center. They could be going to that suprarenal or adrenal glands that sit on top of those kidneys to send out norepinephrine and epinephrine. It could cause an increase in heart rate. It could cause constriction of those blood vessels. We want to try to regulate and maintain everything, and it's done on a negative feedback. Negative feedback tries to return it back to normal as quick as possible. So this video goes through that negative feedback control of blood vessels for you. So we have those chemoreceptors. Chemoreceptors, again, they're at that carotid body. We just looked at on the slide before, and then we have the aortic body. So they're on the carotid arteries and the aorta. They are looking for different chemicals. Oxygen, carbon dioxide, and hydrogen, because too much hydrogen decreases the pH and it can cause that acidosis. That's too much hydrogen in our blood. Hypoxia means we don't have enough oxygen in our blood. Hypercapnia is too much carbon dioxide in our blood. And this is all going to send information into those chemoreceptors, which is going to cause could cause the kidneys to filter out more hydrogen. It could cause you to take in deeper breaths to try to get more oxygen in. and bigger breaths out to try to get rid of some of that carbon dioxide. We have other ways to monitor our blood pressure. Our kidneys are going to play a role in our blood pressure because it needs to regulate the pressure and how much blood is flowing into those kidneys. It does this through the renin-angiotensin-aldosterone system. It's a chain reaction. So when blood pressure or blood volume goes down into the kidneys, those kidneys secrete renin. Renin, and then we have this angiotensin converting enzyme, are going to act to produce angiotensinogen 2. This is a vasoconstrictor. So when it constricts, it makes those blood vessels smaller. So it increases that blood pressure. And that stimulates aldosterone. Aldosterone goes to the kidneys. It comes from that adrenal gland, goes to the kidneys, and it causes us to reabsorb sodium. When sodium gets reabsorbed, water follows. So we reabsorb the sodium, this water is just going to follow the sodium with it. When we reabsorb more water, our blood volume increases. When our blood volume increases, our blood pressure increases. So it's a whole chain reaction. Step one thing starts the whole chain. Epinephrine and norepinephrine, those are those fight or flight hormones. So they're going to increase cardiac output by increasing the force of the heart contractions. It can also vasoconstrict those arterioles. And it helps the cardiac and those skeletal muscles to get more blood flow during exercise, that epinephrine and norepinephrine. Antidiuretic hormone is going to play a role in blood volume because that antidiuretic hormone, we have dehydration or decreased blood volume, causes us to absorb more water, reabsorb. We reabsorb more water back into the blood, our blood volume goes up. Our blood volume goes up, our blood pressure goes up. The heart secretes a hormone, atrial natriuretic peptide. The heart is monitoring the blood pressure and everything around it as well. So atrial natriuretic peptide lowers blood pressure by causing that vasodilation. So it causes those blood vessels to relax. It also promotes the loss of salt and water. So it causes us to filter out more salt and water because our blood volume may be too high at this point, which will reduce our blood volume. So we do have something that works in opposition to antidiuretic hormone, in opposition to that renin-angiotensin aldosterone system. We have something that works opposite of all of that to help reduce our blood volume as well. So this is a nice blood pressure regulation by hormones. What hormones work on what to cause what result with blood pressure. So autoregulation of blood flow. Tissues can adjust how much blood is coming in to those specific tissues just based off of their demand. How much oxygen do they need? How much nutrients do they need while you're sleeping? You don't need as many nutrients and oxygen as you do when you're running. So they can regulate how much blood and nutrients are going to those tissues when you're sleeping versus when you're running. Your pulse. Your pulse, again, is when those ventricles contract, that left ventricle specifically, pushes blood out of the heart, which is going to put pressure on the blood that was already there and continue to push that forward, and it stretches those blood vessels. So your pulse is that expansion and recoil of those elastic arteries. So every time that ventricle contracts, those blood vessels are going to stretch, then they'll relax, stretch, relax. It's strongest in the arteries that are closest to the heart. The arteries that are further away from the heart, it is a lot weaker. It's harder to find. You should be able to find it in your neck, in those carotid arteries. You can usually find it at the base of your wrist by your thumb. That's your radial artery. If somebody's pulse is over 100 beats per minute, it is called tachycardia. It's usually not a good sign. I mean, if they're at rest. If they're at rest and their heart beats over 100 beats a minute, it could signify something. It could just be nervousness. That's all possible. Bradycardia, we mentioned it in the heart chapter again, it is under 50 beats a minute. Endurance athletes can exhibit this bradycardia, these heartbeat, this pulse that's under 50 beats a minute. So here's some of the different pulse points. As I had mentioned, the common carotid artery, you can usually feel it through here. The temporal artery, the facial artery, you can feel it. The brachial artery, the arm, you might be able to find it. The radial artery, this is the one when somebody puts their fingers on your wrist, this is the one they're trying to feel. Even in your foot, you can sometimes find it, the popliteal, the back of the knee, even the femoral. There's a lot of different arteries that we can use to find it. The radial artery is usually the most commonly found. I mean, if you ever have done CPR on somebody, they usually check the common carotid artery in the neck, just because that one is probably the closest to the heart out of any of them that we can check. So when we measure blood pressure, the blue line is the cuff that gets wrapped around the arm. What we're doing is we're actually cutting off blood supply to those blood vessels. And then we slowly let the blood to start pushing through again. So we pump up that blood pressure cuff until it completely cuts off blood supply to that artery. It pushes that artery closed. Then you slowly start letting that blood back in. You use a stethoscope and you're going to listen at that antecubital fossa, the front of the elbow. What you're listening for is as you start to turn the dial to start letting blood to flow through, blood will start spurting through. And you'll hear this psh, psh, psh type of sound. So the first sound you're going to hear is that systolic blood pressure. That is that higher sound. That's that higher number. We hear that first when blood starts to be able to get through that artery again. And then when that sound stops, that's that diastolic blood pressure. You no longer hear that blood spurting because that blood vessel is fully open. And that's how you're able to get that systolic over diastolic pressure. Shock. Somebody who is in shock, they have an inadequate cardiac output that can result in failure of the cardiovascular system to meet the metabolic demands of the body cells. So we're not able to get enough nutrients and oxygen to our cells because we're not getting enough blood pumping out of the heart. When that happens, those cell membranes may start to dysfunction, the metabolism of the cell, they're not able to produce the energy they need. The cells may end up dying. because they're not getting the nutrients that they need. We have hypovolemic shock because we've lost too much blood. This is usually commonly caused by a hemorrhage, loss of too much blood. Cardiogenic, your heart's not functioning correctly. Vascular, your blood vessels cannot vasodilate, so there's not enough blood coming into the area. Then we have obstructive, so something is blocking that blood flow in general. So when your body goes into shock, we're going to activate that angiotensin or run-in angiotensin aldosterone system because we want to increase that blood volume. So we want to increase the amount of water. We want to stop getting rid of water. We're going to secrete antidiuretic hormone, again, to absorb more water, to increase our blood volume. That sympathetic division, that fight or flight, because that fight or flight is going to vasoconstrict our blood vessels, make them smaller. Making those blood vessels smaller increases that vascular resistance, which is going to increase that blood pressure. We can also release local vasodilators. Potassium, hydrogen, lactic acid, adenosine, and nitric acid. They're all going to dilate blood vessels and relax those precapillary sphincters so blood can spread out around the body and get those nutrients to as many cells as we possibly can. So if we go into hypovolemic shock, we've lost too much blood. We're trying to increase our blood volume. So we go to the kidneys. We're absorbing more water. We have receptors in the heart that are monitoring all of this. So the liver, the lungs, we get that renin going, which makes that angiotensin, which also goes to that adrenal gland, which makes that aldosterone, which is going to absorb water. Our hypothalamus and posterior pituitary has got that antidiuretic hormone going. That cardiovascular center in the brain is going to get that sympathetic going. All of this is increasing blood volume, decreasing blood vessels to try to reabsorb more water and try to get our blood pressure back to normal. Somebody who is going through shock, they have cool, clammy, very pale skin. They have an increased heart rate, but their pulse is very weak and rapid. They're sweating. They have that hypotension. So that systolic blood pressure, that first number is under 90. They're usually confused because they're not getting enough oxygen to their brain, so they're usually very confused. They're not using the washroom. They're not excreting out very much. They're very thirsty. They could also have acidosis because there's too much hydrogen in their blood. So there's a lot of different routes our blood can take. The systemic circulation that I've been talking about is that blood that gets pumped out of that left ventricle into the aorta, traveling around the body, getting all of our tissues the nutrients and oxygen that it needs and picking up the wastes. We talked a little bit about that coronary circulation in the last chapter, because that's the blood that is going to the heart. We have a cerebral circulation. That's all the blood that's going into the brain. That pulmonary circulation, that is the blood that's going to the lungs to pick up oxygen and get rid of carbon dioxide. Whoa. Hepatic portal circulation. That is those blood vessels that are absorbing those nutrients from our intestines, go to the liver to store them. And then we have fetal circulation. It's only during fetal life and it's where we exchange materials with its mother. We talked about it with the heart. I mentioned it in the last chapter, and I'm mentioning it again here. So here's this systemic circulation. Again, red is oxygenated, blue is deoxygenated blood. So this is the blood that's going up to the brain. It's going to the lungs here. It's going to the liver, the stomach. This would be the spleen, the intestines, pelvic area, lower limbs. So all of these little capillary beds that it shows that goes back into these veins that goes up to the heart. Here are all the different arteries of the body. It doesn't go into the capillary networks, it just goes into the major arteries here. We're going to go through some of these as we kind of go through everything. We can see, start all the way up here. Coming off the heart, we have that ascending aorta. That is the part that just comes off the heart. Then it arches. That's that aortic arch. Then it's going to start to head down. But as you can see, there's different arteries that are going to branch off. What branches off of the heart? We have this right subclavian artery. We have this left common carotid artery, and then we have this left subclavian artery. And we get this right brachiocephalic artery first. That was my bad. On this right side, we go brachiocephalic that comes off the aorta. And then that brachiocephalic is going to branch into the right common carotid and the right subclavian. That aorta that continues down goes to the thoracic aorta. That thoracic aorta lets off lots of blood vessels that feeds our abdominal organs. It's going to branch off into the legs even. That thoracic aorta turns into that abdominal aorta. That abdominal aorta actually branches into the left common iliac artery. And then it doesn't label it, but we've got our right common iliac artery. And then they're going to branch into external iliac and internal iliac. Then we go to the left femoral. So there's a lot of different things that are happening here. Here's some good examples of an anastomosis going through the knee. This is a really good example of these anastomoses. You can see how these blood vessels branch off. They kind of go around that area and then they come back together. Some of them may go back in, go out, go in. They're all branching around, but they come back into a common origin. That anterior tibial artery. This starts to go into more detail of all of these different arteries. We're going to cover a lot of these in lab, which ones you need to know out of all of these, but these are good images to use to help determine and learn these. I do suggest for the arteries that you need to know, especially the ones that follow branch and change names, to draw them out. Drawing them out and labeling them is probably one of the better ways to learn this. Because we see this ascending aorta, we get that aortic arch. Off that aortic arch, we get that brachiocephalic trunk. That brachiocephalic trunk branches into the right common carotid and the right subclavian. The next one that comes off is the left common carotid, and then we get that left subclavian that comes off of that. It's the third branch that comes off of that aorta. We go into the thoracic aorta, that abdominal aorta. Again, thoracic because it's in the thoracic region, abdominal because it's in that abdominal region. That abdominal is going to split into that left common iliac and that right common iliac. That common iliac goes into internal and external. So all of these are kind of branching out to go to these many different areas. So here's more that kinds of shows the breakdown of all of these different arteries that are coming off of the aorta, off of the heart. You can even see right off of the aorta, right after that semilunar valve, we get coronary arteries, and one on each side, left and right coronary, that are going to come right off of that aorta. That's all feeding the heart. So here's a good showing a good drawing of this. This is going to the head, but this is everything that's coming off that arch. So you see that brachiocephalic trunk that splits, that right common carotid, that right subclavian. This even does the right vertebral artery. That subclavian, subclavicle, below the clavicle, goes to the right axillary, that armpit. Then we get down that humerus, right brachial. That brachial is going to split off into the ulnar and the radial, and that forearm. And then we get to the hand. We have a palmar arch, a deep and a superficial palmar arch that goes through the palm of your hand. And then we get the ones that go to the digits. If we look over here, we get that left common carotid that splits into that internal carotid and external carotid, just like the right one does. And then we get that left subclavian that's going to go down the left arm, giving us the same design on that right side. So here shows it on the actual arm. Here we're going up into the head. We have that right common carotid that goes to the right external carotid that goes to the right, and then the internal carotid, they both split off. That subclavian goes underneath that clavicle. See, there's that clavicle, it's going underneath, and then it turns into the axillary at that armpit area. Here's all the arteries that are going up into the brain. We get that vertebral artery, it merges together. The vertebral artery is the one that goes through those transverse foramen and those transverse processes of the cervical vertebrae as it travels up into the brain. And then it starts to branch off and branches into many different branches around the brain. You guys don't need to know most of these. Here we can see all the branches that come off of that thoracic and abdominal aorta. Here we can start to see these many different branches and what they turn into. We'll go through these a lot in lab in better detail, because you don't need to know all of these. You can see the stomach, the spleen, the pancreas, and that duodenum, that first part of that small intestine. These are all going to have arteries that go to it. So gastric means stomach. We got a splenic artery. We got pancreatic arteries. Mesenteric. We even have the common hepatic artery. That right gastric. Here's our large intestine, found in the middle of all of that. So we have that superior mesenteric artery coming off. It goes, jejunum is the next part after the duodenum. Ileals, that's another part of the small intestine. We have the right colic, ileocolic. Inferior mesenteric. That left colic going to that colon. Here we can see it in a cadaver. All these different blood vessels that are branching off in a lot of these different places. Here's the leg. So that abdominal aorta goes into that common iliac. That common iliac goes into an external and an internal. That external turns into the femoral. That femoral is going to get a right femoral and then a deep artery. That's going to turn into the popliteal. That'll go to the posterior and the anterior tibial. Branching off of that, we'll get our fibular. Pedis for foot, plantar for foot. We have a lot of these that make up part of that foot as well. Popliteal is in the back of the leg. That popliteal fossa, that femoral. Anterior and posterior tibial, that fibular. The veins. Most of the arteries in the body have matching veins. There's a few veins that are different, but most of the veins match the arteries, most. In the arm, we have some different, like we have a cubital, median antebrachial. These are veins that we'll actually draw blood out of. But most of these are very similar. Here you can see some of these sinuses. These sinuses are just enlarged areas and blood vessels where blood kind of pools before it drains out. Here you can see that sagittal sinus that follows along the roof of the skull. You get these transverse sinuses. You have this inferior petrosal sinus, a sigmoid sinus, I said transverse sinus, a right cavernous sinus. So there's a lot of different sinuses in the skull. So down this arm, there's a lot going on here. The basilic is different, the median cubital, the cephalic. These are accessory cephalic. I don't think you need to know all of those, but those are some of the ones that are different. They don't match right up with arteries. So we'll go through most of these. You can see in the hand, there's a lot of different veins that are going through besides those palmar arches and the arteries. We get palmar arches in the veins, but there's a lot more happening going into the fingers. We have a lot of different veins. We have a zygos vein, we have hemiazygos that are going into those inferior and superior vena cava. So there's a lot happening. The vena cava follows the aorta all the way down. We're going to get those hepatic veins, that hepatic portal vein. That's the one I was talking about that goes from that small intestine. Then it goes to the hepatic portal vein to drop off nutrients into the liver before it goes to the heart. The leg, we get superficial and deep. We have a saphenous vein that is different. And that saphenous vein kind of travels that whole length of that leg almost on the inside. We have that great saphenous vein. We have a small saphenous vein. The great saphenous is the one that travels most of the length of the leg. So here's that great saphenous. As I said, it travels most of the length of that leg down. The hepatic portal circulation. So all of these, this superior mesenteric vein turns into that hepatic portal vein that goes into that liver. So all of the stuff, the nutrients that we absorb from that small intestine are going into that superior mesenteric vein, which goes into that hepatic portal vein, which goes into the liver before it goes up to the heart. So this is that hepatic portal system or circulation that is traveling throughout. Here's that pulmonary circulation. We showed it in the heart. We'll show it here. So that deoxygenated blood is coming through that superior inferior vena cava and that coronary sinus into that right atrium. It goes down to that right ventricle. It goes out through that pulmonary vein, the right and the left side, which goes into the lungs. These are all branches into even smaller capillaries where all the exchange happens. They will go into the pulmonary veins, which is coming into that right atrium, that right ventricle, and out that aorta. Or left atrium, left ventricle, sorry. It's my right, my left. So this shows this whole circulation of how everything happens before it gets sent out into the body. Fetal circulation. Here is where some things are different. So we did talk about some of these different parts of the heart. We have that foramen ovale, it's that hole that allows blood to travel from the right and the left atrium, just kind of exchange. We also have this ductus arteriosus, which kind of connects that aorta and that pulmonary artery. These become this ligament that kind of holds the aorta and that pulmonary artery together. And then that foramen ovale closes. It should close at birth. We have umbilical veins that helps to get nutrients from the placenta from the mother. Some of that, after it closes, actually becomes this ligamentum teres that goes to the liver. So here's this fetal circulation. Blood can go through the lung system. It can go just from one side of the heart to the other, go through systemic. It just kind of goes around the body. It's got other areas to kind of travel through, but they get all of their nutrients from the pulmonary system. So our blood vessels. Our blood vessels, because a lot of its connective tissue is going to come from that mesenchyme. That mesenchyme is that embryologic stem cell type of tissue that all connective tissue comes from. And that comes from the mesoderm. And they start at blood islands, as they're called. These blood islands are just groups of these cells that kind of come together, because we have some of that endoderm too, because those epithelial cells comes from that endoderm. And they come together to start making the blood cells and the blood vessels. So as we get older, we lose compliance in the aorta. So that means that our aorta does not stretch as well. Every time those ventricles pushes blood into those aorta, they just don't stretch as well. So, and they don't recoil either. That cardiac muscle starts to decrease in size. It starts to atrophy, get smaller. That cardiac muscle continues to lose its strength. Our heart rate starts to decline because that muscle's declining. And that increases our systolic blood pressure. So our blood pressure starts to go higher. So there's a lot of different, our body, our blood vessels, they maintain homeostasis in most of our systems. In our skeletal system specifically, it delivers calcium and phosphate ions. The blood is going to make sure our bones have enough calcium and phosphate in them. It also transports different hormones to maintain our bones. So that calcitonin, that parathyroid hormone, because those hormones are either going to build or break down. It also, and that erythropoietin, that stimulates blood cells because our red bone marrow. So our blood is delivering all of this to the bones. It helps our respiratory system because we're getting oxygen and getting rid of carbon dioxide. We're absorbing nutrients in our digestive system. We are cleaning out our blood with our urinary system. So hypertension. Hypertension is higher than normal blood pressure. Normal is considered less than 120/80. Someone who has a blood pressure of 120 to 139 is their higher number, or 80 to 89 is their lower number, is considered in hypertensive state. And it's the same thing for stage 1. Their top numbers between 140 and 159, their bottom numbers between 90 and 99, one or the other. It could be both, or it could be one or the other. Same with stage 2. To be diagnosed with hypertension, with high blood pressure, what I was taught in school is blood pressure had to be taken over 3 different visits with a patient and on 3 different occasions over 3 different visits. Because especially the first time somebody comes into an office, a doctor's office, they could be very nervous. And when you're nervous, your blood pressure increases. So your goal is to kind of get somebody to be calm and relaxed. You don't know what they came across on their way to the office, what kinds of stressors they hit on the driving there, because all of that can increase their blood pressure. So it needs to be measured over 3 separate occasions, and all 3 occasions it needs to be high before it can actually be diagnosed as hypertension. Based off of just one visit, we cannot diagnose that as hypertension because, as I just mentioned, we don't know what that patient just went through before they came in. They could have just had a panic attack, have really high stress. All of that's going to affect your blood pressure. So there's some different things that we can do to try to release or reduce our blood pressure, our high blood pressure. Losing weight, as we mentioned, people who are obese, they have higher blood pressure because they have longer blood vessels. Alcohol can increase your blood pressure. Alcohol works as a diuretic, so it thins out your blood because it causes you to filter out, your kidneys to filter out more water, which decreases your blood volume. Decrease in blood volume increases blood pressure. Exercise keeps your heart and blood vessels healthy. Reduce your sodium intake. Maintain potassium, calcium, and magnesium recommendations. Managing your stress. For some people, that is very hard. That's where sometimes stress and exercise come one in one. As long as they exercise, they manage their stress. I'm one of those. So these all kind of just work together. That is everything on blood vessels and hemodynamics. Thank you very much for listening.